Multiple births. Another situation where women are assumed to be ready to do anything to have a baby is not so clear-cut. There are dangers in multiple births, that is, twins or triplets, usually, even though to an infertile woman the prospect of having several babies at once must seem like the perfect solution. The risks of multiple births, which come about in IVF because more than one embryo has been placed in the womb and implanted, the risks are hypertension in pregnancy, greater risk of surgical intervention, increased maternal mortality rate, depression and illness. I'm not surprised. The risks to the babies are low birth weight, increased risk of infant mortality, premature birth, cerebral palsy and other illnesses. The cost to the state through NHS is high. 3 times as much costs for the NHS per twin as per single baby. 10 times as much per triplet. Moreover, since so much of IVF medical practice is private, in effect, the private clinician takes his fee for making the woman pregnant, but the NHS picks up the extra costs if she's carrying more than one baby. When I left the HFEA, my parting shot was to say that. I said it wasn't right that private doctors earned a fortune making women pregnant, often with twins and triplets, and we taxpayers had to pay for the outcome. And that the private doctors should carry insurance. There was a huge outcry, but I thought I was right then, and I still think I am, and I believe things are coming around to my way of thinking. 1 in 4 IVF pregnancies is a multiple birth, whereas the figure naturally is 1 in 80. 40% of IVF babies are twins, and one can almost assume it's IVF when seeing twins these days. Where a triplet or higher order pregnancy has been confirmed, it has been known for doctors, especially in the United States, to offer fetal reduction, that is, termination of some of the fetuses, in order that the others may have a greater chance of being safely born. This may be ethically and practically more distressing than the limitation of embryos to be implanted in any one treatment cycle. There was extensive publicity recently about the octuplets born in the US to Nadia Suleiman. There they are, a pregnancy achieved by one Dr. Kamarava. Maybe this was a personal success for the mother and the doctor, whose published success rate was very low. He is a registered medical practitioner, but not registered as a specialist fertility doctor. And unlike in this country, he can escape inspection and ethical control if working in the US. If ever there was an argument for regulation, British style, it's this case. All the British professional infertility organisations are backing the 1 baby at a time strategy, which means you have to limit the number of embryos used when you treat a woman. Of course, that has to be balanced against the desire of the woman and her doctor to maximise her chances of becoming pregnant. After extensive consultation, the Human Fertilisation and Embryology Authority's Code, the 7th edition, was amended in 2007. And it now says that no more than 2 embryos may be used in a treatment cycle of a woman under 40, and no more than 3 if she's over 40. There's also a policy to move down to using only 1 embryo for everybody, starting with the youngest, healthiest women, because the ideal result is, of course, 1 baby, 1 take-home baby from 1 embryo.